Good afternoon, everybody. First of all, thank you very much to Drs. Dana Tellerman, Dr. Rob Finelli, as well as the program committee and the chairs for allowing me to speak to you here today on the topic of help. Anatomic abnormality and inflammation are blocking my view. As you will see, there'll be some overlap between my talk and Dr. Del Zio's talk, and I will go through those slides very quickly. I have no disclosures. So I'm talking to you about aberrant anatomy. Why am I up here talking about that? Well, because 70 to 80% of iatrogenic bile duct injuries are a consequence of either misidentification of the biliary anatomy, leading to clipping and ligating and further dissecting structures that are misidentified. Excessive dissection along structures, the common bile duct, can also lead to ischemia, stricturing, and further delayed presentation of injury. Additionally, damage to the axial arteries can lead to ischemia and stricturing and delayed presentation. So understanding the anatomy is critical to operating and doing the lap chole properly. Understanding both the biliary anatomy, the vascular anatomy, as well as the context, meaning if there is significant inflammation as a surgeon, you need to be aware that you're going to need to modify, and you need to know what tools you have, especially if your partner's out of town, especially if it's 1 a.m. You need to think about that before the operating room. So my 3 rules for a difficult chole that I always teach my residents: prepare, meaning know your imaging, know your patient's comorbidities, think about the pathology as I just stated, and perhaps most importantly, be patient and persevere. Go through this operation very thoughtfully. This is not one of those cases you try to rush through, or you will be very sorry, as will your patient. One of the transplant surgeons at my institution, I'm in Boston, at Beth Israel Deaconess, and recently he said to me that gallbladders can be the toughest cases and are the most underrated cases in general surgery. And although I did a foregut fellowship, I will agree with that the gallbladders, no matter what the age, but particularly with significant inflammation, they can be the biggest challenge that I face in the operating room. So, as Louis Pasteur said, chance favors the prepared mind. Sudden flashes of insight just don't happen. You really need to know the anatomy, you have to review the imaging, and you have to plan for it before you get to the operating room. So on the left side, you see a schematic of the gallbladder, as well as Calot's, or the hepatocystic triangle, I should say. On the right side, you see an MRCP. So conceptually, we need to be very familiar with that anatomy. We need to be familiar with the read of a cholangiogram or MRCP, because late at night, you're not going to get a radiologist when you've got difficult anatomy to deal with. So I will not go through Calot's triangle. It was very well covered by the previous speaker. Suffice to say, there was a dictum that Calot came up with that I think is very appropriate. The surgeon should not work by sight. Sorry, the surgeon should work by sight and not by faith. In 1891, Calot defended his postdoctoral thesis, and this was the basis of it, as he described this as the more delicate part of the operation. And certainly this is central to understanding the view of safety. So I do agree with the prior speaker that we should forget Calot's triangle, but know this is a very important area of dissection. The hepatocystic triangle is much more regular in its anatomy, and it is bounded by the inferior edge of the liver, the cystic duct, and the common hepatic duct. Just forward through that slide. So with regards to the biliary anatomy, you can have a short cystic duct. This is not an exhaustive list. This is just the more pertinent or perhaps more prevalent variations. You can have an unusual position or course of the cystic duct. You can have a narrow common bile duct that might fool you, especially when you're fatigued or it's a difficult operation with lots of inflammation from the patient's perspective. You can also have accessory ducts. To start with, when you look at the length of cystic ducts, 65% of them are 1 to 4 centimeters when you look at retrospective reviews or imaging studies. 20% of them however, are less than 1 centimeter. So to a surgeon, when you think about a short cystic duct, and if you do a lot of gallbladders, that should make you stop for a minute. You should think about, how am I going to get all of those clips on? In particular, how am I going to get those clips on and they're going to stay on that gallbladder days and weeks and months later, especially in the context of a lot of inflammation. 15% of cystic ducts are actually quite long. That poses an additional difficulty because, in fact, when they're so long and with a low insertion, that can set you up for an injury, mistaking it for the common bile duct. So here's a depiction on the right side of a short cystic duct. And I put this in there because it's so important how you tract or retract the gallbladder. This is something I try to teach residents, and it takes a lot of effort for them to learn this because it's not intuitive. How you're going to grasp the gallbladder, how are you going to hold Hartmann's pouch? It's critical to this operation. If you grasp Hartmann's pouch and retract it superiorly, guess what? You're setting yourself up for the classic injury where you mistake the cystic duct and you actually injure the common bile duct. Additionally, you can have cystic ducts that course from the left to right. So it looks great here on the cholangiogram on the left side, and it also looks great on the schematic, but imagine that there's a lot of inflammation, there is edema, there's invested tissue and fibrosis. You can see how easily you can mistake the common bile duct directly under the infundibulum or directly under Hartmann's pouch if you're not retracting and dissecting out the delicate structures down to detail. With regards to cystic duct insertion, in studies 73% are high, 25% are in the middle, 2% are low. 95% of them are on the right, as we would expect. However, 5% occur on the left side. You can also have extra hepatic ducts, and those pose additional problems if they're unrecognized. For example, it can be confusing in the OR. What's this third structure? A few expletives come to mind when you see that. Additionally, you can have an insertion on the cystic duct, an additional duct. You can have an insertion coming directly off the common bile duct. You can also have a duct going directly into the gallbladder. So all of these extra ducts, if they're unrecognized, they will lead to a leak at the end of your case, or you'll see bile. And that, for any surgeon who does a lot of gallbladders, that strikes terror into our hearts. I can't imagine any surgeon who would look on that very lightly. So with regards to the vascular anatomy, there are also variations. Typically, as most of you know, the cystic artery comes off the right hepatic artery. It can also, however, come off an aberrant right hepatic artery. In up to 20% of cases, it can come off, it can come anterior to the common bile duct, which can be confusing. It can come inferior to the cystic duct, and sometimes it can be short or there can be multiple cystic arteries. It's very important as a surgeon to really think about all of these possibilities and have them at the back of your mind when you're dealing with that gallbladder late at night or in the setting of significant inflammation. The other very important component that I love to ask my residents, they now come in very prepared in my OR for the questions that I pose them because they've not thought about these things, and that is the epidural blood supply or the marginal arteries that run at 3 and 9 o'clock on the bile duct. And they always ask me, why do you always ask that? And I say to them, if you dissect significantly on the bile ducts, you will devascularize them, and that will present as a delayed injury. You need to think about what you're doing. You need to think about where these structures are. The critical view of safety is critical, and our last speaker went over it in great detail. It can never be sacrificed. Even if you have a lot of inflammation, you can never forsake that, or you will end up in trouble. The other anatomic landmarks I love to pimp my residents about: the Sulcus of Rouviere, Hartmann's pouch, and the valves of Heister. I think 1 out of 10 of my residents know these structures, and it's very important to know them. And as I teach them, it's more important to know them in the elective setting, because you can actually see them, so that when you're in the acute setting and there's edema everywhere, you have a good idea. So the Sulcus of Rouviere runs on the right side of the hilum, anterior to the caudate. It can be identified as a scar, it can be a slit, It can be open or closed depending on the definition. It's very important to recognize it because typically about 78% of the time, according to studies, this is where the cystic duct actually comes off the common bile duct. In any case, you don't want to dissect below this area. And if you do, you will end up in trouble. So Hartmann's pouch, demonstrated here in a Netter diagram on the left side, is that area of the infundibulum. So Hartmann's pouch is very important to conceptually know where it is because it sets you up how you're going to retract and expose Calot's triangle, or the hepatocystic triangle, so that you can set yourself up for success. Hartmann's pouch and the valves of Heister, they're not that important other than when I see them, I know I've got the cystic duct. And you can see them if you look for them. So with regards to retraction, I've mentioned it a couple of times. You want to take your lateral grasper, at least this is how I was taught in my training, and this is what I do every time. And it's always a step-by-step recipe. So the fundus is retracted over the dome of the liver with the lateral grasper. The medial grasper is used to grasp Hartmann's pouch to the right lower quadrant, and those are critical moves. And if you don't do those, you're setting yourself up for difficulty. And as I alluded to earlier, if you take Hartmann's superiorly, well, that's going to be the classic injury that we know and I'm sure have discussed many a time because you mistake the common bile duct. If ever you have unclear anatomy or you have extra structures, you should stop, you should pause, you should be very thoughtful, and at that would be the appropriate time to do a cholangiogram, and I know one of the speakers will talk about that also. So I'm not sure if this projects very well. This is an 80-year-old female presented with acute cholecystitis 2 days before I came here. It was a very difficult dissection. Surprisingly, her ultrasound was not very impressive, so I figured I could get this done and then go off to my meeting. It was quite the challenge. But the take-home points here are the same that I've given all this lecture, and that is think about the landmarks, do not compromise on your critical view of safety, know your bailout maneuvers, know where your partners are. And I know somebody else will be covering all of the maneuvers that you will need to know when there's significant inflammation. I would add that never be afraid. Pride should never be a part of this operation. If you need help, call for help. And these are cases that can certainly challenge all of us. So with the summary of my talk, we've talked about the anatomy, we've talked about pathology, we've talked about the important issues around imaging when needed, and be patient and persevere. Thank you very much.